Hello, I am Raymond Kwong, a clinical cardiologist and the director of cardiac MRI at the Brigham Women's Hospital. I'm a professor of medicine at Harvard Medical School. I'm happy to be with you today to talk about the use of Gatavist, also known by its generic name Gatobutrol. Gatavist is the first and only gadolinium-based contrast agent, GBCA, indicated for use with magnetic resonance imaging to assess stress and rest myocardial perfusion and late gadolinium enhancement in adult patients with known or suspected coronary artery disease. Today, I'm going to show you some examples of cases of how I have used Gatavist to aid in imaging our patients. Please note that I am being compensated by Bayer to support this presentation.
It is important to know that intrathecal administration of GBCAs can cause serious reactions, including death. Gatavist is not approved for intrathecal use. Additionally, GBCAs increase the risk for NSF among patients with impaired elimination of the drugs. Avoid use in these patients. The risk of NSF appears highest among patients with chronic, severe kidney disease or acute kidney injury. Screen patients for conditions that may reduce renal function. For patients at highest risk, do not exceed the recommended dose.
I will demonstrate the cardiac MRI methods by showing a case from a 63-year-old gentleman with a history of multiple coronary risk factors. So the current MRI techniques has high resolution. What you're seeing is on the left are the stress perfusion imaging, and the middle column are the rest perfusion imaging, and on the right upper panel is the late enhancement matched by the same cut of cine imaging on the right lower corner. Note that the stress and rest perfusion imaging has high resolution to about 1.4 millimeters in plane, and a blood flow map is generated from the respective stress and rest imaging in the color panel below. These patients undergo the cardiac MRI perfusion imaging without any need for any breath holding or post-processing because the blood flow maps are generated automatically. This gentleman had a prior history of CTA recently and was noted to have moderate stenosis and was treated medically. He now came back with troponin elevation and recurrent chest pain. And note that the incremental additional information you can learn from the cardiac MRI demonstrating markedly reduced blood flow in the left anterior descending territory during stress, which is different from the low blood flow at rest. You can see a reversal of blood flow in the stress and rest images. Before we move on to the next cases, let's review details on Gatavist clinical trials. Gatavist is proven in clinical trials for cardiac MRI. Bayer conducted two multi-center open-label phase 3 studies to evaluate Gatavist enhanced cardiac MRI for the detection of coronary artery disease in adult patients with known or suspected coronary artery disease. The patient population was broad and enrolled patients with known or suspected coronary artery disease of any risk level based on signs and symptoms. Patients were excluded from the study if they had a history of coronary artery bypass grafting, or if it was known in advance that they were unable to hold the breath, or had atrial fibrillation or other arrhythmia likely to prevent electrocardiogram-gated cardiac MRI. Patients underwent Gatavist enhanced myocardial perfusion, including stress and rest imaging, and late gadolinium enhancement imaging within one session to ensure time-optimized examination, and a single standard dose of Gatavist at 0.1 milliliter per kg of body weight was used, divided into two separate equal injections for rest and stress perfusion imaging. The high concentration and relaxivity of Gatavist enable image enhancement with a single divided dose of contrast. The co-primary endpoints for these studies were sensitivity and specificity of Gatavist enhanced cardiac MRI for the detection of coronary artery disease in adult patients with known or suspected coronary artery disease. Quantitative coronary angiography was the standard of reference. A total of 764 patients were evaluated for efficacy and 904 patients for safety across these two global multi-center trials. This slide shows the high diagnostic efficacy that was demonstrated with Gatavist enhanced cardiac MRI across the two pivotal trials. For each study, images were read by 3 independent readers. Reader detection of coronary artery disease depended on visually detecting defective perfusion or scar on Gatavist cardiac MRI, including stressed rest and LGE imaging. Quantitative coronary angiography, or QCA, was used to measure intraluminal narrowing and served as the standard of reference. The left ventricular myocardium was divided into 6 regions. Interpretations were provided per region for cardiac MRI, reporting presence or absence of perfusion defect and or LGE, while QCA results showing presence or absence of stenosis of more than or equal to 50% or greater than or equal to 70% were provided per artery. These tables show the sensitivity, which is the detection of disease when stenosis was greater than or equal to 50% or greater than or equal to 70%, and specificity, which is the exclusion of disease when stenosis was less than 50% or less than 70% across 3 independent blind readers evaluating cardiac MRI images for each of the 2 pivotal trials.
Gatavist is contraindicated in patients with history of severe hypersensitivity reactions to Gatavist. Anaphylactic and other hypersensitivity reactions with cardiovascular, respiratory, or cutaneous manifestation ranging from mild to severe have occurred. Before Gatavist administration, assess all patients for any history of a reaction to contrast media, bronchial asthma, and/or allergic disorders. Acute respiratory distress syndrome has been reported with Gatavist. For patients demonstrating respiratory distress after administration, assess oxygen requirement and monitor for worsening.
The next case, I will show a 60-year-old gentleman who presented with acute chest pain in the emergency room. When he presented, he had no troponin elevation, and ECG was also negative. And a cardiac MRI study was achieved in about 25 minutes and reached a diagnosis. So what I'm showing here on the top panel is the stack of short axis functional imaging, or so-called cine wall motion imaging, which demonstrated no regional wall motion abnormality at all. On the bottom panel demonstrated the matching lane enhancement imaging. In the matching short axis, you can see that there is no gadolinium enhancement to demonstrate any infarction. Even though these are more benign images, in the same study, the perfusion during stress or rest were more concerning. What you're seeing is perfusion images on the left panel, the apical slice, the mid slice in the middle column, and the right column demonstrate the basal cut. On top is the stress perfusion. On the bottom are the rest perfusion images. You can see that in the LAD territory, or in this area, involving the basal to mid antral septum and anterior wall extending to the apical septum, there is a dense perfusion defect or qualitative assessment, which is not present at rest on the bottom, suggesting that there is a tight perfusion, there's a serious perfusion defect, a dense perfusion defect correlating to a tight LAD stenosis. Now, what is actually not so obvious is when we actually use the myocardial perfusion mapping, you can learn additional information as well. Not only did it show the hypoperfused area as I demonstrated in the last slide, you can see that there's an additional perfusion defect in the inferior wall, as demonstrated in the mid-inferior wall here, and the basal inferior infraseptal wall here. There is a good amount of hyperemia, suggesting the regadenoson or vasodilatation actually work, but there is what is not clear from the qualitative, but is shown in the quantitative perfusion mapping, is that there is a second perfusion area, hypoperfused area in the circumflex territory. So indicating that this is not just a LAD ischemia, but also circumflex ischemia as well. And the patient went on to have coronary angiography, and it's not surprising to see that he has a very tight culprit proximal LAD lesion, as seen here with a thrombus. But in addition to that, there's also a second tight stenosis in the circumflex territory that accounted for the patient's symptoms. He went on to have percutaneous coronary intervention of both lesions, and his chest pain subsided afterwards. Here's another case of a 65-year-old gentleman who presented with exertional dyspnea for about 3 weeks. On the top panel is where you can see the stress perfusion imaging arranged by the basal short axis cut, the mid short axis cut, and the apical short axis cut. In the same orientation on the bottom are the rest perfusion images. You can see that there is a perfusion defect during stress involving the anteroseptal wall at the base, anterior wall in the mid, and also a perfusion defect involving in the septum as well, but is most easily noted in the basal and mid level. And these perfusion defects are by and large not present at rest, suggesting this is a reversible perfusion defect. When we see the late enhancement imaging, there is not evidence of infarction. There is a small foci of late enhancement, maybe indicating a very, very small scar. Now, the perfusion defect being so much larger than the late enhancement area, suggested that this is a reversible perfusion defect caused by a tight stenosis in the proximal LAD territory. He went on to have, indeed, the patient actually had an angiography around the time of the cardiac MRI. It was initially thought that there is no stenosis in the proximal coronary artery territory, and the patient was sent home on medical therapy and was told that he had no significant stenosis. But based on the MRI findings, we requested that he be sent back to the cath lab and had another look at the LAD territory. And this time they performed a invasive fractional flow reserve imaging and quantified the physiologic significance of the LAD lesion. And one can tell that is actually a significant lesion as predicted by the cardiac MRI, with an invasive FFR value of 0.75. And therefore, with this repeated coronary angiogram and this abnormal finding as inferred by the cardiac MRI, he now underwent, a month later, a coronary stenting of the LAD, and his symptoms completely subsided within a week.
Gadolinium is retained for months or years in several organs. Linear GBCAs cause more retention than macrocyclic GBCAs. Consequences of gadolinium retention in the brain have not been established, but they have been established in the skin and other organs in patients with impaired renal function. Certain patients may be at higher risk. Consider the retention characteristics of the GBCA and minimize repetitive GBCA studies when possible. In patients with chronic renal impairment, acute kidney injury, sometimes requiring dialysis, has been observed with GBCAs. Do not exceed the recommended dose as this may increase risk. Extravasation into tissues during Gatavist administration may occur and result in moderate irritation. Ensure catheter and venous patency before injection. The most frequent adverse reactions associated with Gatavist in clinical studies were headache, nausea, and dizziness.
Thank you for reviewing these case studies with me today. I hope you find it useful to see how we use Gatavist imaging to assess stress, rest, CMR myocardial perfusion, and leg gadolinium enhancement in adult patients who present with known or suspected coronary artery disease.